So next we have one of our alumni lecturers. This is Dr. Rivera. He is originally from Phoenix, Arizona, and he completed medical school at UCLA, then did his emergency medicine residency here at Kings County, where he was one of our chief residents. After residency, he completed the Multimedia Design and Education Technology Medical Education Fellowship at the University of California, Irvine, and received a master's in education. He's currently practicing at UC Irvine, and he's also serving as the assistant clerkship director for the emergency medicine rotation, is the dean scholar for the clinical foundations course, and works with the diversity, equity, and inclusion group. His interests outside of education focus on social determinants of health and caring for underserved populations. So thanks so much for coming, Dr. Rivera. We're excited for your lecture.
Hi, everybody. Good morning. Can you hear me okay? Awesome. Thank you. So I'm just going to do some adjusting. I shared my screen. If you want to do some live audience participation, feel free to jump on to the Nearpod link or go to nearpod.com, and I'm going to throw the link in the chat here. I will warn you that when I created the QR code that's on the first slide of the presentation, I had to go out to put the QR code back on the presentation and come back in, and it changed the session number. So the QR code that's on the first slide won't work. So use the link that's in the chat, or just go to nearpod.com and put in that code that they have on there. And I'll let everybody jump into the presentation first. I figure it's early in the morning and all we want to do is audience participation, right? I have to say I'm super excited to be back in lecturing. I miss you all so much. Just so you know, working on the West Coast has reminded me how amazing the training is that you receive at Kings County, and how amazing the patient population is, and also just how amazing the leadership has been, and how formative it is to have such a resident-focused residency, and that I miss you all every day. And so I won't say if there's any coast is better, but I definitely miss working with you all. And I definitely miss the physician leaders that you all are, and the amazing things you do outside of the clinical space as well. Something that I've yet to just run into anywhere else in my travels so far. So thank you all for being a part of that. So yes. Oh yeah, and we also wear pink on Wednesdays. That's part of how I'm trying to change the environment in my hospital, is that we are queering up spaces by wearing pink on Wednesdays. I wanted to start my presentation with a case, if that's okay with all of you. So I'm going to tell you, you've got a 6-year-old Hispanic male. He's brought by emergency medical services in respiratory distress. His mom speaks only Spanish, and she states that the child may have asthma and was treated in the ER about a few times in the past, including they had a visit 2 days ago. The child's grandmother is the main caretaker and was the one who brought him in last time. So they're not really sure what medications he received or what medication he was supposed to be taking. The grandmother did tell the mom that a phone interpreter was used to communicate with her, so that he did speak in Spanish with the translator. The mother has an asthma inhaler for the child, which was given to her a few months ago, and it's now almost empty. And then she has a prescription for another inhaler and another medication, which she hasn't had the time to fill yet. On arrival, the patient's in moderate respiratory distress, tachypnic, severe inspiratory and expiratory wheezing. He has persistent coughing. Mom states she's not sure who the kid's primary care doctor is, because she usually brings him to the ED when she has a medical concern. She also states he was given a color-coded paper during the ED visit that was supposed to help her understand how bad the child's asthma is, but she really doesn't understand it, and she doesn't have it with her right now. So after a few rounds of treatment, the kid's doing better and is ready for discharge. Considering this history and presentation, I want you to think about ways that you might help this family going forward. Let's see, we've got students, we got 12 of you in right now. So out of curiosity, what do you think? Why did this child come to the ER? Sorry, this is okay, language barrier, I like that. Did not understand how to use home meds, health literacy, difficulty filling meds. Okay, great. Medication access issues. Anybody have an idea of what medication she was supposed to fill at the pharmacy that she may not have filled? Dulera. I like that. Also, maybe what do we send kids home with for a couple? Not everybody does, but some physicians still send people home with steroids. Exactly. So it might have been steroids that the child was supposed to be on. Good, excellent. So then my next question for you is, did having two caregivers, do you think it affected his care, and how? And if you want to join the lecture at any point, the code is at the top. It's just nearpod.com, and you can go to this code ESAWT, and that'll let you in. Oh, you know what? Sorry. Nearpod has this new setting that makes me approve all the posts. I apologize. So we got, okay, so maybe they weren't on the same page. Sorry, I'm also going to make this anonymous so that we can all share things anonymously. Older caregivers have harder time coordinating, navigating ambiguous instructions between two caregivers. Good. Handoff communication, right? We do this all the time. We know that things can be missed in the handoff, especially in people who aren't trained in how to do that. Sometimes it can be positive depending on communication. I agree. Yeah, having sometimes two people in there can also help as well. So I like that you're thinking about it from a positive way. Excellent. All right. Last question I have for this portion. What could have been done to prevent this patient's bounce back? All right, so language appropriate discharge instructions, right? Mom didn't understand that color coded piece of paper, which was probably like an asthma plan. Take home meds, in person interpretation services, primary care follow up, discharge instructions in the right language. Yeah, really a close PCP follow up, and even knowing who the PCP is, right? Like better ways of letting people select their PCP instead of auto assigning it. Coordinated care and communication for the follow up. Very good. Even like written discharge instructions in the patient's language, like our communication to the patients. Oh, and read back instructions. I like that. So that, like one of the things that is shown to be effective in getting patients to understand their discharge instructions, right, is read back. Really good. So I think you're all catching on to the main point, which is health literacy is kind of one of the things that is part of this scenario. So I will introduce this is a social determinants of health lecture about health literacy, created with myself and one of my mentors, Dr. Sangeeta Sakaria. So I want to talk to you a little bit about health literacy, and then just for funsies, if we have time, I threw in a bunch of stuff about medical mistrust and like anti-vaccinationism. If we can get to that, we'll have some fun talking about those topics as well. So today, my objectives for you are to understand the importance of physician communication, improving healthcare literacy. I also want you to understand the role of like language fluency, education, and culture, and how it can shape health literacy. We'll talk a little bit about health literacy as a major contributor to decision making, and then recognize the need to help patients find information and services that will better their overall healthcare. All right, so most people ask me like health literacy, what is it? What is it good for? So I think this is there are a couple of different types of health literacy that are important. So I'm going to break it down by the types. There is something called personal health literacy. So this is defined as the degree to which an individual has the ability to find and understand and use information and services to inform their healthcare related decisions, to make decisions about actions for themselves and even actions for others if they are the caretaker for somebody else. Some examples of this might be of personal health literacy can be things like understanding prescription drug instructions, which you touched on, understanding the doctor's directions, understanding consent forms, or even the ability to navigate a complex healthcare system, even sometimes the ability to navigate a complex healthcare campus, right? Getting around, knowing what building you have to go to, things like that. The next part of health literacy that I like to talk about is the organizational health literacy. So, organizational health literacy is defined as the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform their health related decisions for themselves and again for others if they're the caretaker for others. So, things like this might be simplifying the process to schedule an appointment, using, like you touched on before, the teach back method to ensure patient comprehension, and providing communications and language appropriate materials and in reading level appropriate materials and in visual formats that are appropriate for the patient itself. The third category that we have is more important nowadays as we have gone through a COVID pandemic and we have seen that medicine can be practiced pretty effectively and arguably effectively in digital form through like telehealth and things like that. We're seeing more and more things done on iPads in the lobbies, consents done on iPads, mobile charts where patients are seeing their results in real time before we even have a chance to go and talk to them about their results. So, digital health literacy is going to be defined as the ability to seek, find, understand, and appraise health information from electronic sources, right? So, that's when and then take that knowledge you've gotten from an electronic source and apply it to address solving a health problem for yourself or somebody else. And examples of this are things like we talked about electronic health records, being able to communicate electronically with your healthcare team through things like the portal, having a cell phone available to call or a telephone, because not a lot of people have landlines anymore. And this is also going to come into like a little bit of good internet citizenship, in which you are able to discern reliable health information from unreliable health information. And then also understanding like how to use health and wellness apps, but also how to use those health and wellness apps appropriately, so that you're not actually, you're not using the wrong ones, or you're not using bad information that's like telling you to do all kinds of crazy things, like drink bleach and inject ivermectin or whatever it is that people have been doing lately. Another thing that we have to think about is numeracy, and this is a type of literacy. Basically, it's the ability to have mathematical and advanced problem solving skills that are necessary to succeed in society, that is driven by data, driven by technology. So examples of numeracy are things like understanding nutrition information, right? Like understanding how do calories come together to make, carbs and protein and fats come together to make calories, and understanding what a portion is and how to make a portion size. This could be interpreting blood pressure readings or blood sugar readings from one of your machines. This could be taking the correct dose of a medication, understanding to take one or two or one half or whatever it is every however many hours, or understanding how to convert 3 times a day to how many hours in between your doses. Other things that can be is evaluating like the percentages of the benefits and the risk of a treatment that a doctor or a physician is proposing to you. And then understanding the insurance cost, your insurance coverage, copays, co-insurance, what's covered, what's not covered. These are all elements of numeracy that arguably in the United States, Americans have some difficulty with. So why are there some reasons that we have difficulty with this? We have lack of educational opportunities. People in the United States have an average of how high would you say the average reading level is in the United States? You show fingers. Uh, Eighth grade, exactly. So seventh, eighth grade is the average reading level. Most people, you can take like their highest achieved education level and subtract a couple grades, and that's generally why they have that reading level. Part of it is because of learning disabilities. Part of it is because you get a cognitive decline as you age. But then the other part of it is like you have to use it or lose it. So if you're not in a job that requires you to use these skills or use mathematics, then you start to lose that and you regress a few years. So typically they say, subtract 3 to 5 grade levels below the last year of school that they've completed. And that's approximately the education level that you should be working with your patient on. So for many of our patients, that's like, sixth grade, seventh grade. And our reading materials and things should be looking like that. All right, so I have another question for you. How do you feel culture affects health literacy? I think this is a really awesome question for us in a place like Kings County, where you have multiple cultures that are combining together and you see patients from, within minutes, you might see patients from multiple different cultural groups. There we go. So less of a cultural focus on Western medicine. Good. So people who want to use their own like traditional healing methods, cultures can dictate how a disease process is managed. Good. Or understood even, right? Like I remember at one time had a patient who was concerned that their neighbor put a hex on them and that was the cause of their abdominal pain and vomiting. And it's like, how do you navigate that to be like, well, I don't do hexes, but I do like nausea, vomiting, and I can help with those symptoms, and kind of figuring out a culturally responsive way to work with them. Differences of how symptoms are described. That's so important, right? In Vietnamese culture here, we have a very large Vietnamese population in Irvine, and sometimes things are described using like sound effects, or sometimes things are described as like hot or cold. So I have heat in my belly, could be like a description of abdominal pain. And the patients with different backgrounds might be hesitant to new recommendations. Good. Not from this. Yeah, there can be like a disparity if you're not from the same cultural group, that they may not trust you. Good. Excellent. All right. Oh, I love historical instances of harm by the healthcare communities. It's like you're all reading my mind and you know exactly what's coming up in this lecture. So good. So why is health literacy important? This is a survey that was done basically that showed that people have, very few of our patients have a proficient healthcare literacy level. Most people are intermediate, and then the rest of the other majority are below basic or basic. And we can't call patients basic, so don't do that. Just know that their healthcare rating can be basic. So another survey that was done, if you do it by race, you can see that there are some differences in healthcare literacy in the United States by race and US populations. And then another thing that we can look at is healthcare literacy by type of insurance, because this makes a difference, right? If you're in a public system like Kings County, where people have a public insurance, this is also represented in how and it's really funny because sometimes insurances can get more complicated the more they are public. Sometimes they get more simple, that it just depends on what system you're working within. Important statistics: 9 out of 10 people struggle with health literacy. It's estimated that about $100 to $200 billion of healthcare cost annually are due to poor health literacy. And I think this is things like repeat ER visits or worsening of medical conditions presenting late in the disease process. So what are the consequences of poor health literacy? I think we're starting to see people have longer hospital stays, they have more ER visits, people make more medication errors, they have trouble, managing their chronic diseases. And the most important thing is they skip preventative medicine services like flu shots, COVID vaccinations, those kinds of things, and the things that are really important, especially after we're coming out of a global pandemic. I also like to talk about medical mistrust as a form of healthcare literacy. I think it's important because we want to, like, medical mistrust is according to the WHO, it's the World Health Organization, it's one of the 10 largest global threats in 2019, that we're starting to see a return of diseases that we have never seen before, that people are getting infected with things that we have considered eradicated in the past. And so that's kind of scary that there are hotbeds of supposedly eradicated diseases coming back. Another thing that's really scary is that we have poor control over like our general and novel diseases, right? So we're talking about COVID-19, we're talking about annual flu, we're talking about pneumonia vaccines and elderly people living in nursing homes as well. And again, this is that part where we talk about delays in worse health outcomes for things like breast cancer. This growing medical mistrust can also be associated with underutilization of healthcare, delays in seeking out care, lapses in recommended screenings for things like breast cancer or colon cancer, poor self-reported healthcare status, decreased mental health status. Delay in this care will harm a patient. It'll harm their families potentially if they lose a family member who's the caretaker for them, or that's the breadwinner for the family. And then they're more likely to succumb to medical misinformation if they are not engaged in the healthcare system. Someone who's not engaged in the healthcare system is more likely to fall prey to medical misinformation. So it's important to talk about some of the historical factors that contribute to this. And I think some of you alluded to this before. I think one of the most important things we can talk about is this idea of medical error that contribute to people not trusting the healthcare system and avoiding healthcare. So about 250,000 Americans can be considered to die each year from some medical errors. Some would argue that it could be reported as the third leading cause of death in America. And so that makes you question, like, why would people trust a system that quote unquote makes so many mistakes? And the thing is, like, a lot of it is not necessarily physician mistakes. A lot of it is not necessarily individual mistakes, but it can also be things like mistakes or systemic problems, right? Where there's access issues, there's ability to access care, ability to get quality care issues that exist, ability to pay for care, those kinds of things. The other part of it is in the United States, it's so expensive to get healthcare, right? So 20% of healthcare spending in the US is considered wasteful. We have one of the most incredibly expensive healthcare systems in the world without enjoying the benefits of that, like, extra spending on the money. We still have really poor healthcare outcomes that are used to define good quality healthcare. So like maternal fetal death, what's called the age that we live to, like the age of death is still pretty low compared to the other OEC countries. And so that's the other question: is why should Americans and our patients trust a healthcare system that is so wasteful? Like, if that waste is applied to them, then they will not want to go to the doctor. I got a haircut yesterday, and the woman who was cutting my hair said that she doesn't go to the doctor because doctors just bill you all the time to get your insurance money. So if she's a young healthy person, why would she let them bill for that insurance money? We talk about Dr. Marion Sims, who we call the father of modern gynecology, who did medical experiments on slaves and the children of slaves. So when the medical community puts people like this on a pedestal, it kind of creates a disparity between our patients. We should all be familiar with the Tuskegee experiments, in which 600 Black Americans were enrolled in a study and 400 had syphilis. And the study continued on even though we knew penicillin was a way to treat people, and they were allowed to see the sequela. They were not treated to see the sequela of the disease, and they were not given a proper informed consent. We have to talk about Henrietta Lacks, who her cell lines have contributed to almost all of the cell lines that we use in healthcare today, and yet her family was uncompensated. This was like the first time that we were able to replicate in vitro cells. It came from it's the HeLa HeLa cell lines. And so this is one of the most important contributes to the world, contributions to the world of science today, but she never received the credit or compensation to her or her family that for this contribution to the scientific community. And it was done without her permission, right? No consent. In the United States, we have to think about Native American health. So there was historical ethnocide and genocide where we were taking children away from First Nations families and putting them in with non-First Nation families to try to Americanize them and culturally make them more white. There's the Havasupai Diabetes Project, in which people were money supposed to be given to treat diabetes in this community, but instead it wasn't used properly, and the community suffered very greatly with higher levels of complications of diabetes. Forced sterilization of over 3,000 women by the Indian Health Services in the United States, and then outlawing native practices of like traditional. We talked about traditional healing, and our First Nations Americans have some of the poorest health outcomes in the United States. I think an important thing to think about is, this is one of my favorite quotes about it, is that every like person who had medical mistrust, it's created, perpetuated, and sustained by structural inequalities in the healthcare system. So thinking about how that contributes to these things. For example, like in 2014, Black males and females had a lower average life expectancy than white males and females. They have higher blood pressure for Black males and compared to white males. There are lower influenza vaccination rates. So in Black and Latinx populations aged over 65 compared to like white and Asian populations. And it's also a strain on mental health. There was a 2015 review that found that racism is strongly associated with mental health problems, contributing to stress, anxiety, depression. And this is really especially true in the United States for Asian American and Latinx groups. So something to think about of how our system contributes to this. I also think it's important to think about some everyday factors that we can address with our patients. So access and education, right? Like who has access to the internet, who has access to appropriate information, who can connect with the healthcare system? Do our patients actually use the EMR that they have access to in Epic, or are they still asking for paper forms and copies of things? Can they request records that they need in order to transfer to other physicians so that they can continue their care? Internet's expensive. I don't know if you have all noticed, like the internet prices are going up, so it's really difficult to maintain good high-speed internet to use these websites that are getting more and more complex and requiring more and more bandwidth to run on computers. And it's interesting that a lot of people don't understand how to differentiate fact and fiction online. So if you Google vaccines, almost 40% of the content that comes up is still anti-vaccination information. So like, and it also depends on knowing how to Google things, right? If people aren't taught how to use search engines, you might Google, are vaccines bad for you, or benefits of vaccines or harms of vaccines? And so we don't, like, you will get a biased answer. Whatever you put in is what it's going to return for you. So if you don't use a generic question, you don't get a balanced perspective on it. You'll get just the one that supports the narrative of what you typed into the Google search bar. Healthcare coverage and insurance, right? We see this every day. You're a public institution where people come to get care. So there's huge economic and racial disparities for patients. About 20% of Black adults in 2014 couldn't access health insurance compared to 10 in white and Asian populations. For Latinx populations, it was 35%. And then there was a 2012 study that showed predominantly Black zip codes were 67% more likely to have a shortage of primary care physicians. And I think this is something we run into when we see those long wait times that patients have to wait in order to see a primary care physician and follow up after leaving the emergency room. There's like a huge difference in trust among physicians, right? So we talk about physician-patient relationship for vaccine decision-making, and then not just the physician-patient relationship, but when you've got a pediatric patient, like the physician-parent-patient relationship, that triad that's going on there. So this suggests that, and pro-vaccine campaigns that rely purely on trust in the medical community or purely on trust in physicians really aren't successful. They don't work. The Ontario Medical Association did a campaign in 2019 called #AskOntarioDoctors. And it was a way to try to combat medical misinformation with their tagline saying things like, "You've got vaccine questions, ask a doctor, not the internet." It was like trying to build this like narrative that you can ask your doctor these things instead of trying to go to the internet or asking your tia, or asking your friends on Facebook, because it's better to ask the person who's been trained and know. So what their study showed was that a lot of vaccine hesitancy was linked to a lack of trust in physicians, because patients don't understand the perspectives that we're coming from. We are trained in this idea of data and numbers numbers and like it reduces your risk reduction, harm ratio, hazard ratios. And we understand these concepts, but patients don't. What they found instead is that patients understand like narratives and emotional storytelling. And so if we can adopt strategies like that, where we can tell stories about patients who were harmed by not being vaccinated, or talk about our experiences in working through the pandemic with a bunch of people who were not able to be vaccinated because we didn't have a vaccine, those emotional narrative stories have much more impact on patients than numbers or statistics or like commands or paternalistic medicine that someone might practice saying like you have to get this. So we also have to think about politicization of healthcare in the United States, right? We have a huge problem with this, partially because our news outlets tend to like take things and go to extremes with them for the fact that we like clicks, we like clickbait articles. Sometimes the article title has nothing to do with the content of the article and gives a completely false representation. The other thing that we have to remember is this is partially our fault as well, because we've had the name of like popularity and marketing, we do these press releases where we like institutions, like large institutions and good research institutions will press release a paper before it's been peer reviewed, saying like we just completed this research study and here are our results. But then it gets peer reviewed, it gets torn to shreds because the methods are all bad, and then it gets sent back and it never gets published. But the public has this press release that they saw and the media ran with it. So there's this happened a lot during COVID, right, with like ivermectin and other treatments that people were pushing. And then the other thing is people do pre-release papers where they will actually release the paper before it's actually published, and that goes directly to the internet instead of going through like a publication warehouse where it's peer reviewed. So where people are skipping the peer review process, which is pretty difficult. It makes it hard to, one, if that paper gets retracted, that information is never communicated to the public that paper was retracted. So they only have the bad information. They never get the updated good information. We talk about implicit bias in healthcare. I think this is something that you're probably all intimately aware of. There are a 2016 study found that white medical students wrongly believe that Black people have higher pain tolerances than white people. And they looked at like these not true healthcare false beliefs, and they found that 73% of medical students held at least one false belief about biological differences between races. For example, like Black people might have larger muscle mass than white people, that's why they're better at sports. They put a bunch of these like false healthcare beliefs into a survey, and 73% of students going into medical school still held at least one of those. There are things like Black people might have thicker skin or less sensitive nerve endings or stronger immune systems. And these are like centuries old beliefs that we just have not been able to eradicate in the healthcare system. And in the 19th century, doctors were using these terrible beliefs to like justify doing inhumane things to other patients and to the people that they were doing their research studies on. In addition to limited access to trauma centers in predominantly Black areas, evidence does suggest that racial bias may prevent people of color from receiving emergency care because of avoidance of emergency care and not having access to it. There was that Frontiers in Pediatrics study that said doctors in emergency departments are less likely to give Black and Latinx children pain medications, or that they were deemed as having less emergent situations compared to white and Asian children. And they were less likely to order like CTs, blood tests, x-rays for Black, Latin, and Asian children compared to white children, which may also be a portion of like the practice environments, right? Like in Kings County, you practice a bit more of a cost-saving practice environment and evidence-based practice environment compared to a place like Irvine, where like if a patient comes in and wants a CT scan, many of the physicians will just give them so that they don't have to argue with them. Other things that we have to think about are things that come through in the media. I apologize, this can be kind of an emotional moment for some of us, but if everyone remembers Dr. Susan Moore, who documented and was putting her experience with COVID up online and on social media as the doctors were denying her care and telling her that she was pain seeking as she was like dying of COVID, and essentially she died of COVID and what arguably people would say from poor care. So those are some of like the factors that contribute to this. I think we also have to talk about the role of conspiracy theory, because it's a huge portion of what goes on in the United States. So we'll talk about conspiracy theories. On average, this is like a really cool study where they looked at like conspiracy theories and things that people believed and tried to get a sense of like what were the characteristics that led someone to be more likely to believe in a conspiracy theory. And on average, people who believed in conspiracy theories tended to be less educated, poor, or members of minority groups. And it wasn't that they were conspiracy nuts who are like ignoring their health. It's that they're normal people who are trying to make sense of complex issues, but just don't have the tools and don't have the requisite healthcare literacy to make sense of these complex issues. People who backed conspiracy theories were less likely to rely on their family doctor for information. They were more likely to look to family and friends for information, and they were more likely to go to the internet and rely on like celebrity doctors and celebrities for their information. So the people who relied on celebrity doctors like Dr. Oz and Dr. Wheel, they were more likely to favor conspiracy theories also when reverse tested. And there was almost 80% of those patients who liked celebrity doctors agreed with at least one of those their like false theories. They think that they're accessing more reliable sources of healthcare information than what traditional medicine is providing, right? Everyone feels like they want to be like on the cutting edge of things. They want to know the secrets. Like, what is my doctor not telling me? This one simple trick that you can do to cure cancer, right? You've seen these articles all over social media. And so this is why it's taking hold, is because people want access to information they think they're not getting access to, which comes from a distrust of healthcare, comes from a distrust of the government, comes from a distrust of other people. Some of the common medical conspiracies that we think about is that like the FDA and the government are holding back cures for cancer, that fluorination of water is to cover pollution in the water so that we will drink polluted water, that doctors vaccinate despite knowing the risks, so that we don't know the risks and we give vaccines anyway because we don't know the risks, or that your cell phone might cause cancer. Any other medical conspiracies that y'all can think of that you love that are fun to share?
I think just you kind of mentioned it, just you know, we're billing and getting paid for medications and things that we're prescribing and stuff like that, that we're getting kickbacks in some way.
Yeah, I'm still waiting for my vaccine check from COVID, man. Love that fat check. Agreed. I love it. Things that like we don't want people to use natural remedies, like like the alkalizing or acid, doing alkaline or acid treatments to your body is somehow going to change the way that the way that you experience your illness or cure cancer, things like that. Good. This is really interesting. I didn't think about this until I think Jon Stewart did a segment on this, about like medical mistrust, and like and I never thought about it, but like how many of you have gotten like a WhatsApp conspiracy theory from a relative, or like a Facebook thing where they send it to you and they're like, you need to know this before you treat patients? Did any have any of you got these? Or how many of you have like La Tia de WhatsApp, who like is always sending you stuff on WhatsApp, uh, and all the different ones? And then it's problematic because these are groups of people who create these like social network bubbles with each other in groups, and none of the information is screened for truth, like how Facebook has those, or will have this thing saying this is probably false information. None of this information, and it spreads really fast, right? Because if you have 20 people in a WhatsApp group and 20 people share it with 20 people, and they do that 5 times, that's 3.2 million shares of false information through something as simple as forwarding a text message or a WhatsApp message to a group of people. And if I think about it, I have way more than 20 people in my contacts list that I can forward this stuff to. So there are lots of this information spreads very fast, and there are very few opportunities to combat it. So I want to talk a little bit about the role of misinformation and how it complicates the picture. I think that we talked a little bit about it earlier, just to clarify some of the points. People don't know how to fact check. There are language barriers, right? So Facebook exists in many countries in different languages, but when the news story is in a different language, Facebook in the United States has difficulty fact checking the information in the other language. So you may not get those warnings of false information. There's also country barriers. So things like certain social media platforms don't have the same resources dedicated to like flagging false information. So depending on the platform that people are using, it may not have the ability that Facebook has, for example. And then YouTube and other channels haven't really been monitored for false information as much. It's starting to get better now, but this is a picture of this guy. He calls himself King Vietnam, and they call him like the Alex Jones of Vietnamese media. And like oftentimes I go into like my partner Quan, I'll go to his family's house, and I can hear this guy in the background, and it's like it's crazy. The stuff that they say is wild. Okay, so I started to introduce to you a little bit about this emotional approach, right? This is how they get people to believe false information. It's always a story about a child or a friend or a family member who died. There are usually very few facts to the story, but lots of like name dropping or institution dropping to get those like credibility points in there. In these cases, the facts don't matter. What matters is that like emotional touch and the feelings that it evokes in the reader. There was a study of about 265 university students between the ages of 19 and 36, and many of them were women. It was like almost primarily women, and they were provided a description of a fictitious vaccine along with fictitious narratives from those people who were vaccinated. And researchers manipulated the frequency of vaccine-related adverse events that were reported in the narratives. Ooh, Sorry, my screen just totally blacked out. Give me 1 second. Ooh, that was wild. Okay, everything just turned off for a second. Sorry. The participants were given credibility of, you can all see me okay? Yeah, my camera just turned off. Sorry, let me fix that real quick. There we go. Good. Okay, we're back. So the participants were provided with like the credibility of the website, or told like what websites they were accessing and things like that. And statistical information about the occurrence of events. And the results showed that the narratives had higher frequency of vaccine events, and people perceived that as like the greater risk. So they went with the ones that showed narratives. They weren't able to differentiate the risk based on facts and things like that. So we are starting to see that it's really about the storytelling, it's about the connections, about the emotion, more than it is about statistical things. That patients don't care about the statistics or the facts, really, right? They care about the emotions more. There's also this really cool idea of like drug disgust and like health purity. And I think this is something that we see a lot as emergency medicine physicians, that people don't want certain treatments from us because they're like not pure, or they're like they're I don't know, that they're toxins that go in the body. So there's this suggestion that like vaccine hesitancy is rooted in this idea of a purity attitude, and that it can cause like a disgust response in people. And so people who have higher levels of disgust sensitivity are associated with disapproval of gay people. It's also been associated with ethnocentrism and social conservatism. There are studies that show undergraduates and the general population have higher levels of disgust sensitivity with negative attitudes towards vaccination, suggesting that there's this like that these things may be that this disgust sensitivity is a motivating factor towards vaccine choices, like whether you will take or won't take vaccines. There's something also called moral foundations theory, which proposes that moral decisions are often made using quick and emotional judgments, with like you justify your decision with post hoc justifications after the decision is made. So some of the work in this field has shown that vaccine hesitant parents will strongly emphasize the moral foundations of purity and liberty, the ability to make the choice themselves, rather than like my school or my government is forcing me to get these vaccines. And then, we are at an hour, yes?
Yeah, but the next one doesn't start for 20 minutes. We should take a
Okay.
little break in between, but you
Sure.
have a
Let me
minute.
let me start closing down here. Okay. So yeah. So basically, the idea is that like people depend on their morality. They depend on this idea of independence, and that like they also have this idea of disgust sensitivity. So these are things that we are working against in the medical community, and to get people to believe and take the treatments that we suggest, or to engage in their healthcare. There's also this idea that there's an anti-mainstream movement in the United States, where people are kind of like, well, I don't want to do what everyone else is doing. I want to be an independent thinker. So this is like the idea that there are alternative facts or alternative treatments. So people want to downplay the seriousness of things to suggest that simple cures are more important than complex cures. So that drinking, lemon rind ground into water will cure your cancer, but chemotherapy will kill you instead. And then so people also try to avoid cognitive dissonance. I think this is a really important thing, that people will bend their beliefs to match their narratives instead of like realizing that they're not correct. They'd rather bend their beliefs and then change what they like, make justifications for it later on. It's kind of like game theory. So this is why Q was like a QAnon is so popular, because this is like game theory. If you put a bunch of things in together and you tell people that there is a message in it, they will find the ways that all of these facts and figures or things are related to each other. Just like an escape room, they'll try to like put the pieces together until they come up with something that makes them feel successful or accomplished, that like they understood the message. And so that's why cults are so effective, right? Because even when the event that the cult predicts that the world is going to end on a certain day, even when that doesn't happen, the people who are in that cult have such a strong belief in those ideas that they will then change their narrative and update their beliefs and justify why it didn't happen. So that's something else to think about that we're dealing with, which is like, look, we just want to practice medicine sometimes. These are all of those things. Like, why can't we just practice medicine? This is that John Oliver sketch I was telling you about that talks about some of this medical misinformation over the internet. And I think what we're really interested today as our group is like, what do we do as physicians? Because we can't fix the education system. We can't fix people. We can only practice medicine. So I think one of the best things that I try to remember in this situation is the quote, "When I know that you care, I'll care what you know." And so understanding that when patients feel our care, when they feel our love, when they feel our compassion, they tend to believe more what we are offering and what we say and what we do. Also, I think so much of the responsibility of stopping misinformation gets placed on individuals or on companies, like social media, like on individuals like you and I, that we have to, like, in our appointments with patients or in our interactions with patients, have to stop this misinformation. But we also have to place the onus on the companies like Facebook, YouTube, other companies where information is being traded. They should be responsible for fact checking the information and giving people the correct access to unbiased opinions. And then we kind of can work within our families. Like, that's what we all did during COVID, right? We would answer 100 text messages a day about people asking us for questions about things and what should they take, what should they not take. I think also we have to work on public trust. Unfortunately, the history of medicine has not been kind to everyone, and there are still huge healthcare inequities that exist that if we don't correct those, we can't expect patients to come to us and trust what we're doing. And that's unfortunate because we're fighting against the tide of history, and we need to make medicine more transparent, more understandable. We need to educate people so they can understand healthcare. Um, so it's like we get stuck trying to undo the past by making healthcare more accessible. We have to make it more equitable and more evenly distributed with better healthcare outcomes. And then we have to know about that first. So doing things like this, where we're engaging in lectures and learning about inequities and things like that, is also a big important part of that. We have to do community engagement, right? There was the Black barbershop trials where we found that patients who had physicians who shared lived experiences in them. So Black patients with Black physicians, for example, they were more likely to take a blood pressure medicine or more likely to get their annual vaccination because they trusted that doctor understood their life and understood where they came from and wouldn't harm them in any way. And that's not to say that, like, that a Black patient has to have a Black doctor, but it's just that we have to have some understanding of the lived experiences as our patients in order to connect more fully with them. And I think this is also important that we make it easier for people to access healthcare. These doctors went to the barbershops where people were getting their haircut regularly and were interacting with people regularly. So we have to make it easy for people to access care by giving, like, childcare for people who need to go to the doctor's appointment, having 24-hour access to primary care instead of like the 9 to 5 when everyone else is working. And then we also have to bring the vaccines to people. For example, when we were trying to vaccinate on Catalina Island, it was really difficult. So we actually had to go to the island with boxes and, like, walk around the island and vaccinate all the residents because we couldn't get them all to come to the hospital. We were literally sitting at the docks as people were coming over and vaccinating them as they were coming over. And then we have to tell stories, right? We're seeing that this evidence shows that emotional narratives, oral traditions, these are some of the most powerful tools at our disposal. So we don't only want to rely on facts, but rather want to rely on the emotional journey or helping use our stories, because you have powerful stories. I went back and I read my journal from when we were working during the COVID pandemic in the early months, and I cry every time I open that journal. And, like, even thinking about it now, I can't even think about those times without getting teary-eyed because it's so emotional. So sharing those stories for patients can really have an impact on them. There's also this idea of the truth sandwich that you can do to help patients feel like you're on their side also, you're taking their side. So you take one truth from the information that they've brought to you and then explain one falsehood from the source, and then add your own truth that isn't from that source, that's from outside in your medical education. We have to take advantage of that disgust response, right? People have those disgust responses to impurity, to, like, I don't want to take medicines. My body is natural. My body will do what it needs to do. But you can also take advantage of that by showing them the negative consequences of not treating their illness, and how much intubation, how much living on pressors, how much living on machines is unnatural also. So we can encourage them to protect themselves from these unnatural outcomes by taking care of their health, getting preventative medicine, taking vaccines, and things like that. And of course, the last thing, which I don't think any of you have problems with, is that we have to start talking about empathy. We have to start talking about compassion, understanding how much of what people are experiencing in their lives contributes to their attitudes about that. We can't just look at our patients and call them anti-vax or crazy, but instead pause, ask questions, and work within their frameworks, and create better, closer relationships. We have to understand that some patients are just too literate, right? Like, is it possible for someone to be too literate? They've read too much, they know enough, they don't know what they don't know, but they know that they know a lot. And so these are some of the patients you see demanding MRIs for everything. I just want to point out that there are, like, just if we want to talk about evidence-based things, because I love evidence-based medicine, there are some tools to evaluate healthcare literacy. So there's this thing called the REALM, which is like the rapid estimate of literacy in medicine, where you ask people from the lists to, like, talk about these words through the lists. And it helps you to understand, like, what their grade level is by for their ability to match these like words together. There's something called the TOFHLA, the TOFLA. It's like a rapid estimate of people's health literacy. So you actually have these questions where it's like, your doctor has asked you to have a blank X-ray, and it's like they have to decide which one fits in there. It's a way to assess health literacy. That's the gold standard right now, the TOEFL. There's also this one they call the new vital sign, which is where they have you read a patient read a health label. And if the patient's able to understand questions about the health label and read the health label, that can be a really good sign of healthcare literacy. And there's also this single item screening tool where it's just like a couple of questions that you ask people and to assess their health literacy. This is a study that was done looking at discharge instructions because I know that discharge instructions are so difficult for patients to understand. Interestingly, they took a bunch of, like, they took a one-page paper and they had like a diagnosis, medications, supportive care, and the patient literally wrote down, filled out the sheet while the physician was talking to them in triage at discharge to see if that would help them to improve their healthcare literacy. And it worked a little bit, but still didn't work great. Teachback still is like the only thing that works well. This is just some important universal things that we can do, ensure that people have access to health information. We use plain language health materials, provide trainings, create clearinghouses of information about health literacy for health professionals, and review health materials with patients to make sure they understand the information that they're being given and specifically what actions they need to take. If you have time, we can do some practice ones on here, but otherwise I can stop there. That is everything I have for today. I'm happy to answer questions or let you do some practice questions, whatever you want to do. I have like 3 examples if you want to try your hand at it.
If anyone has any questions, let's do that. If not,
Yeah.
I think the examples would be awesome. Anyone have any questions for Dr. Rivera?
Great job, Ronnie. Good to see you flourishing out there.
Thank you. Thank you very much. And listen, every day I'm telling people like Kings County's the place, man. I would not be successful if it wasn't for my experiences at Kings County. I'm very excited to say I'm going to be recording for EMRAP a little bit later today. So I look forward to sharing with you when that gets released. So I'm excited.
That's awesome. So proud of you, Ronnie. And my question was going to be surrounding kind of like individual engagement with patients. So I think maybe I'll defer to your examples and we see where that goes.
Okay. All right. Well, this is the first example. A mother asks you to evaluate her baby's poor weight gain. What are some things that you want to consider with health literacy when you're working with a baby who's having difficulty gaining weight? They're not all emergency medicine based examples. I apologize. And feel free to just shout it out. Like I'm cool if you want to just like yell out loud.
Is mom breastfeeding?
Is mom breastfeeding? Good.
I think there can be different cultural feelings about weight and about nutrition and what infants or babies should be eating and drinking.
Yeah, when I was working in the lactantes ward in Mozambique, the moms would all say, "Make my baby fat like an American baby." Right? There is this idea that like the roly-poly, like fat fold baby is the ideal for the baby. So what does she consider poor weight gain, right? Is that something that's actually documented in the chart, or is she just thinking that the baby's not looking healthy or big enough? Or is there some other illness at play that she's saying is poor weight gain, but is actually like something else, like the baby's sick or septic? Thinning the formula. I'm glad somebody talked about this, right? This is something where people don't realize they may not necessarily have the numeracy to mix the formula appropriately. So they might be making it too thin or stretching it to make it last longer. And so, yeah, so they may not know how many cups or how many spoons or what the measuring sizes are. Very good. Like percentiles, good. So the baby may be growing appropriately. Excellent. Excellent. Or maybe the mom has other children and doesn't realize that like the child is growing appropriately for their age, but maybe not as big as other children that they've had in the past. Good. All right, let's try the other one. A patient with hyperglycemia is having their 3rd ER visit this week. This is classic emergency medicine. And they're asymptomatic. How's that sound? Sent in from clinic for a blood sugar of 200.
I mean, I think always the big thing here is adherence and talking about some sort of nutrition thought process. And also, for me, highlights the systematic issues too, right? Like, why does this prompt an ER visit? Like, by the time we see these patients, they've now been at clinic waiting however many hours in the waiting room. And our approach is kind of like, Yeah, it's not that bad.
Yeah, totally. And I love some of the examples. This is exactly it. It's like the understanding like what constitutes an emergency. We have problems within the healthcare system with that, right? Let alone patients understanding what constitutes an emergency. I love the idea of not understanding how to administer correctly, not having access to it because of cost. Are they homeless and can they store their insulin in a refrigerated place? Do they know their regimen, right? How many patients get discharged on new regimens but never switch to the new one because it's not clear in the paperwork because nobody goes over it with them, but we hand them a paper that says stop this med, and then on like 2 pages later it's like start this med, and they're like, oh, we're supposed to stop this insulin, not start. And like, yeah, they only read the first page of it, and so they think they're supposed to stop their insulin. Diet, understanding high glucose, and food access. Exactly. If you can't access healthy foods, then how are you going to keep your blood sugar well controlled? Excellent, excellent, excellent. And then this is how about a patient with late stage breast cancer being admitted for failure to thrive. And thank you, Dr. Soldier, for talking about numeracy in Kings County patients in the chat. I appreciate that. It is one of the bigger problems we have in the U.S. Is our ability to do numeracy. Well, sorry, I have to make sure everything is auto approve.
I think this issue sometimes can be on the side of the physician or medical culture, but this kind of not able to accept that, that's just part of the experience and the human outcome, and admitting someone with a terminal disease for failure to thrive, when maybe we can look for other options.
Yeah, absolutely. And I also love that the group is picking up on things like discussion of goals of care with the patient, understanding their diagnosis and religious beliefs, and even sometimes there's family dynamics, right? Where like if a child is taking care of a parent, the idea of putting their parent on hospice is like giving up or killing their parent, right? And so it's hard to make decisions like that because it feels like you're betraying the person who you love. Another dynamic here that I think about is like, why is the patient presenting with late stage breast cancer when breast cancer is oftentimes a curable disease when caught in early stages? So was there some sort of missed screening? Was there some sort of misunderstanding about home breast exams, or the patient didn't have access to care or the ability to go to get a mammogram early on in the course, and it ended up being late stage as well? Good. And what does your life look outside the hospital, right? If you're all by yourself and you have no supports, you're more likely to come to the hospital for things like failure to thrive or not having the adequate support or hospice and things like that. Really good. And then the last one I have is a 22-year-old patient who comes to the ER with COVID. Normal, healthy 22-year-old with no medical problems, has a sore throat, fever to 100.3, comes to the ER. The bane of our existence for 3 years.
I was going to say, is this in 2020, 2023?
Let's say this is now. Because, yeah, and it still happens, right?
Happened yesterday.
Absolutely.
I personally try to approach it with grace. I feel like there's still fear and a lot of uncertainty surrounding COVID. I mean, so many people, like you said, reading your journal, so many people have such tragedy related to this. So
yeah. And maybe they have high risk people at home and they want to make sure that they're okay. They need a COVID test because they can't afford to buy one on their own. Scared about COVID. Other things I think about too are like maybe like we don't have a lot of healthcare literacy in the United States, so people don't understand how to treat a cold, right? People don't know what decongestants are. They don't know that like Tylenol is good for fever and pain, or ibuprofen, those kinds of things. So sometimes like not everyone lives with mom and dad, and these young adults who are like out on their own for their first time, they're like navigating, right? And they're finding resources for themselves. So it's an opportunity for us to teach. I need a work note. Yep, that's a big one, right? Because we live in a system where we're productivity focused, and if people can't produce, they need a doctor's note to say why they can't produce for their employers. Yeah. Other parts of this too, I think about are like sometimes patients they have healthcare guilt, which is something that I think about often. Like I didn't get my vaccines. I don't take care of my health. I've been eating poorly lately. I've gained weight. So I'm guilty and I'm worried that something bad is going to happen to me because I'm sick now. And that maybe something I did contributed to this, or maybe they want Paxlovid because they aren't vaccinated and they heard that Paxlovid helps, or they want ivermectin. So yeah, there are lots of health literacy things that occur in these situations. All right, good. I'm pretty sure that was the last one. So I just wanted to say thank you all very much. I really appreciate you engaging with me and letting me come back to work with you. I have to say there are not residents in the world that are like the residents at Kings County and City Downstate. So please have a lot of pride in where you come from, and it's kind of like a curse. You go out to do amazing things in the world later on, and keep in touch with each other. And if anybody has any questions about working in California or wants to get in touch about social determinants of health, those kinds of things, please definitely check in with me and let me know.